Great, thank you. So today I'm going to be talking about quantitative imaging and how we use microcomputed tomography to look at characterizing changes in tissue and also how that affects function in preclinical models of lung injury. So just a quick a plug for the Center for High Throughput Phenogenomics. So we are a facility in the Faculty of Dentistry. We are a shared facility, so anyone can use. And we have a number of electron, light, and X-ray imaging techniques. We're currently serving 7 faculties at UBC and other users from outside. And if you're interested in any of our equipment, you can scan the QR code, which will take us to the website. We also offer tours monthly, so there will be a tour next week if you're interested in that. So the instrument that I use very heavily at the Center for High Throughput Phenogenomics is the in vivo micro CT machine. So this is a X-ray CT scanner designed for rodents, mice, and rats. We can get high resolution of 25 to 100 micron, which doesn't seem high to the people who are used to scanning electron microscopes or TEM. But it's pretty good for anatomical imaging. We can do pretty fast imaging, about 3 minutes for a 3D volume image of pretty much the entire body of a mouse. And we can do physiological gating, which allows us to synchronize image acquisition with physiological signals, so cardiac or respiratory. So how are micro CT images made? So we have a beam of X-rays that are incident upon our rodent or tissue. And some of those X-rays are going to be absorbed by the tissue, and that will give us differential contrast between different tissues. And the other X-rays will pass through and strike the detector. And so what we have on the detector is a map of the transmitted beam. And so on the far side, we have an image of a mouse. So in the XY direction, or in the plane of the detector, we can see how the different tissues are distributed. But we don't have much information about the Z direction, so along the direction of the X-ray beam. So we don't know how thick our mouse is. We don't know how that thickness is changing across its body. So if we add different angles all the way around, we can reconstruct a 3D representation. And by looking at different angles, we can start to figure out the distribution of all the different organs and how they are shaped, sized, distributed, distance between them, and all of that. So that looks like this. So here's an image of all of the projections that we took of a mouse all lined up. So you can see a lot of the anatomy is stationary, but in the very center of the screen, we saw something that was moving very quickly. And so that is the diaphragm of the mouse. So the mouse was alive, anesthetized, but alive, and free breathing. And so it was breathing a lot. And to deal with any artifacts, if you take pictures of things that are moving, you have lots of motion blur. So to deal with the blur, we do respiratory gated imaging. So we use a little pillow and we place it underneath the mouse. And as the diaphragm moves, it squishes the pillow, and we end up capturing that signal with a very sensitive pressure transducer and feeding that into the machine. So we can put it into a gated mode where it waits until it gets a breath before it fires the X-rays. And so this is an image of what the mouse looks like with the pillow. You can see just underneath here is the little pillow. And we can measure in real time the respiratory trace. So this is a real respiratory trace of a mouse under anesthesia. And then I've superimposed some little respiratory windows. So that's the red bars showing where we would target to get inspiration, where the lungs are full. And then the second one is our expiration, when after the mouse is exhaled. And so we can delay until the breath happens and then acquire our image. So we use all of this to study models of lung injury. So I'm going to give you 2 examples of lung injury studies that we've done. So the first one is looking at lung injury following high doses of radiation. So these are all of the people who worked on the project and the sources of funding. So our high doses of radiation are radiation therapy for cancer. And we focused on lung cancer because it is the leading cause of cancer in North America. And the survival is pretty low. So cancer treatment has been doing very well, but not so much in lung cancer. So the 5-year survival rate is less than 20%. Radiation therapy is used quite extensively. Nearly 80% of patients will have radiation therapy, and half of them will experience some sort of radiation-induced side effect. So there's lots of side effects to radiation therapy that are fairly generic. In the chest and thoracic irradiations, we end up finding radiation pneumonitis and fibrosis in the lung. So those are the two that we're going to focus on as our markers of lung injury. So the standard of care is to deliver daily radiations over 4 to 8 weeks. So the patient would go in every day, 5 days a week, and they would get a dose rate of about 0.04 to 0.09 gray per second of a dose, and then over many weeks, they build up to the full prescription dose. More recently, there's been interest in ultra-high dose rate radiation therapy. So this is a little on the experimental side still. But it's defined as having a dose rate greater than 40 gray per second. So you can imagine that's a huge increase in how quickly the radiation is deposited. And so we can get very short exposures with the same dose. And there have been a couple of studies to date looking at this ultra-high dose rate, or also known as flash, using electron beams and proton beams. And they've shown good tumor control and reduced side effects. So our research question, we wanted to know if we could deliver kind of a flash dose using X-rays, and can we use micro-CT to detect these respiratory side effects? So to do this, to get this ultra-high dose rate, we can't just use a regular X-ray tube. So we actually went to Triumph and did it there. So we had to build an end station. So it took a lot of designing and modeling and all of that to get a target that we could place in the beam to produce the X-rays that we wanted. Then we had to come up with how to hold a mouse, because they don't normally do mouse stuff at Triumph. So we had to come up with a way to reproducibly position the mouse within the holder and make sure that the mouse was able to survive in there. So maintaining body temperature, adequate airflow, that we would be able to monitor it. So we had video cameras involved. Turns out mice fit really well into 50 milliliter Falcon tube. So they're perfect mouse shape, perfect mouse size. So our first attempt was to just drill holes in it to see if we get some air in there. But then we couldn't see the mouse, so we thought that might be a problem, because the mice under anesthesia eventually will wake up. And in this scenario, they have to have injectable anesthesia. So they're down for about the time you think, but plus or minus a margin of error. So we didn't want to have a problem where a mouse woke up partway through in irradiation. So we needed to be able to see it so that we could have the video. So this is actually the video feed, a still image from the video feed. So you can see the mouse in the holder right here. This is the nose end. It's got a little cap on the end with a bunch of holes in it so the mouse can get lots of air. And we could monitor in real time and watch the mouse during the irradiation. So then we had to test it with our live mouse model. So we came with a couple of different prescription doses. So we had a 0 dose group, so that's our control. They only got anesthesia, no irradiation. And then we had 2 treatment groups. So one got a 15 gray and the other one got a 30 gray prescription dose. And then each of those prescription doses were split into 2 groups. So half of the animals got the conventional dose rate and half of them got the flash dose rate. And so you can see the flash dose rate that we achieved was nearly 100 gray per second. So we were able to take something that would take 5 to 10 minutes and deliver that in about 1/3 of a second. So very fast. So we expected radiation pneumonitis would be an acute early stage, and that the fibrosis would be more chronic, and so that would occur later on. And so we monitored with micro-CT. So we did a scan at the beginning to see what the animal looked like before, and then every 2 to 3 weeks out to 12 weeks. And then our endpoint scans were at 18 to 24 weeks post-irradiation. So we were able to deliver very similar doses to all of the animals. So this is every animal we irradiated. Pretty good agreement. We got better agreement for the 30 gray group because we did some additional conditioning and stuff of the beam to make it a little bit better. So our first pass was to look at the images and see if we could see anything with our eyes that looked like it might be radiation pneumonitis. So these are a little bit pixely from the projector. But we have our baseline scan, a 9-week and 12-week, all from the same animal. So in the baseline scan, we have kind of the heart here. We have lungs, which are dark. So all the air spaces are dark. And in the 9-week, you can see the 1/2 of their lungs has kind of filled in by this red arrow. So those filled in spots is fluid building up inside the lung. So that's our radiation pneumonitis. And then at 12 weeks, you can see it's cleared out. So we know it's radiation pneumonitis because it came and then it cleared again. So we did detect radiation pneumonitis in a number of animals in the 9 to 12-week range. For the fibrosis, I'm going to show you a video scanning, scrolling through. So we're going to start at the spine and go down to the sternum. And so you can see that there's darker areas up here, but there's areas of the lung that are quite gray. Hard to see a little bit in this room. This side here is grayer, and that side over there is blacker. So 1/2 of the lung is much more filled in than the other. And then we looked at histology as well. So the center column is our same mouse as in this video, and then on the far side is a control mouse. And so it's hard to see from a distance, but we have 3 different magnifications. And you can see the control one is a lot more uniform looking. So we have nice little round alveoli with fully enclosed in tissue, which is the part that's marked in red. And in our radiation therapy case, we can see that there's a lot of clumps of tissue where there's a bunch of red and purple all mixed together and not a lot of airspace. And then other places where there are air spaces, there aren't a lot of septa. And so in that case, we wouldn't expect the animal to be able to breathe quite as well. So the purpose of having these little tiny sacs with lots of tissue around it, all the way around it, allows more air exchange. So it gives us a large surface area for gases to exchange. So in the case where they're all kind of morphed into one big airspace with no septa, reduces the surface area for gas exchange to occur. So here's a couple more histology images. So this is showing our control, flash, and conventional exposed animals for the 15 gray group. The 15 gray group didn't show a lot of damage. The damage for the flash was limited really to the outer edge on the right side of the lung. That's where the beam entered from. And the conventional was a little bit more widespread, but there wasn't a lot to see in these 15 gray groups. The 30 gray groups were a little bit more pronounced. So you can see a lot more color and a lot less airspace. So the flash, there were some fairly significantly damaged areas, but the rest of the lung looked okay. The conventional, it was a little bit more widespread throughout the entire lung. So we definitely did experience some fibrosis in these areas. So I purposely am showing kind of the worst things that I found. So their whole lung doesn't look like this because they wouldn't be able to breathe at all. But this is just kind of the worst thing that it looks like. So we have a few mice that showed radiation pneumonitis. We didn't see radiation pneumonitis in all, and that's typical of what happens in patients as well. Not every patient will experience this, or not every patient will report it, because radiation pneumonitis would seem to a patient kind of like an infection. So they might feel like they've caught in a cold, and really it's radiation pneumonitis. So they don't necessarily report, and for the most part, they're able to clear it on their own without any medication. So we did see a few. I think if we had sampled more finely and done weekly imaging during weeks 8 to 12, we probably would have seen more. We had pretty good agreement between the fibrosis on the micro-CT and the fibrosis on histology. And then we also did some quantitative analysis. So because we have 3D images, we can actually do measurements. And so we measured the volume of the lungs at inspiration and expiration, because we had a pair of images at each of these time points. And so we could measure in every mouse. And so you can see we have a little bit of an upward trend, and then it kind of flattens out. But at the very end, our 30 gray animals showed a drop-off for both inspiratory and expiratory volume. And these were significantly different from the control animals. So we can see that there is a loss of function here. The animals weren't able to breathe as much air in to their lungs. And we can use those measurements to calculate some of the metrics that are used clinically. So in the first plot here, we have the functional residual capacity. So this describes how much air is left over in your lung after you exhale. You can't exhale all of the air. You have to have a little bit left inside. So how much air is left? And on the far side is the tidal volume. So that's basically how much air is exchanged per breath. So that's basically the difference between the two volumes that I showed on the previous slide. And again, we see significant differences from our control group. So we're able to see the size of the lungs, we're able to see the function of the lungs has declined. So to answer our question, can we use micro-CT to detect these things? And we can. We were able to detect both radiation pneumonitis and fibrosis. We had much more to look at in the 30 gray groups. So the 15 gray group was very similar to the control mice in terms of their lung metrics, but we saw declines in lung function for the 30 gray for both conventional and flash. And then what we would need to do next is to do some tumor-bearing mice. So we haven't gotten to that stage of the project. So these were normal, healthy mice. We're showing a reduction in the side effects, but we also want to make sure that we're still achieving tumor control. So the next step would be with tumor-bearing mice. So the second project I want to highlight is looking at lung injuries following cigarette exposure. So this was done in collaboration with Don Sin at St. Paul's. And so here's the whole team and all the funding. So cigarette smoke is the leading cause of chronic obstructive pulmonary disease, or COPD. And it affects about 250 million people worldwide. Even though the incidence of smoking tobacco is declining, there are still lots of people who are suffering from COPD. And in fact, COPD is projected to be the third leading cause of death by 2030, which is a lot closer than it was when I started this project, just around the corner. Unfortunately, there aren't any drugs that are curative for COPD. The only drugs that exist are to treat exacerbations. So basically, patients will have flare-ups where they're unable to breathe well, and most of the time that will lead to a hospitalization. And in 2010 in Canada, that was about 10 days per patient on average and about $10,000. And then most of those patients would be readmitted very soon thereafter. So it is a bit of a problem from that sense, and these patients just continue to decline. So COPD is progressive. So it begins in the small airways, and then over time, the tissue begins to degrade and the lung function begins to decline. It is staged. So the early stages are known as GOLD 1 and 2. This is marked by increased lung volume, decreased airflow, small airway changes, and emphysema, in kind of a mild emphysema. And as it progresses into stages 3 and 4, the airflow is reduced by 30 to 50% in GOLD 3, and then by more than that in GOLD 4. These patients have difficulty breathing, even doing kind of normal everyday things. So walking up a flight of stairs. GOLD 4, they might even get out of breath just getting dressed in the morning. So they are very debilitated. This category of patient has a lot of hospitalizations and often are on oxygen. So there have been some studies previously looking at COPD in rodents. These previous studies have been in mice and guinea pigs, hamsters, and they've shown at about 6 months post-exposure to cigarette smoke, the symptoms of COPD begin, and they're looking at histology and biomarkers. So this is a post-mortem study. So we wanted to know if we could do this in vivo, and then we could potentially monitor over time the same animals. So can we see any markers in the lung structure and function that are related to exposure to tobacco, cigarette smoke? And can we detect any changes at earlier stages? So in the literature, it was basically 6 months is when it starts, but it wasn't clear if it was 6 months because that's when they looked, or 6 months because that's when it starts. So we used mice. So we exposed female mice. We chose female mice because in both patients and in mice, the COPD is more severe in females than males, even for the same exposure to cigarettes. So we decided to kind of pick the harder hit group because we're more likely to be able to see at earlier stages if it's more severe. And then we did imaging pre-exposure and post-exposure. So we had groups of mice that were exposed for 1 month or 3 months or 6 months. And each of those groups had control animals that were breathing regular room air, and then some of the animals were breathing cigarette smoke. And so we used research cigarettes, so they were calibrated to have precisely the same amount of nicotine. They were exposed in a 1.5 hour session. I believe they got a break halfway through. And they were exposed 5 days a week for 1, 3, or 6 months. So on the far side is the apparatus that we use. So I have a video of them calibrating it, just so you can see it in motion. So the top row of ports here are the intake. So when the syringes pull up, they draw air in through the intake and then push it out through the ones that are longer at the bottom. And those ones would be connected to tubing and then to a nose cone. And then the mouse would be placed where it could have nose-only exposure. And then if you can see, if you watch carefully, this one, it will draw up. When they turn it on, it will draw up smoke. And so it will look very cloudy. I think it's the next draw. So that last syringe is now very cloudy because it's pulled up all that smoke. So all that smoke is now going to be pushed out the exit port to where the mouse would be. And so here are some example images from 3 different mice. So this pair is our 1 month, in the middle is the 3 month, and the far end is a 6 month exposure. So the mice are a little bit bigger as we go across because they gain weight as they age. So they're physically larger mice. But if you look closely, you might be able to see the 6 month lungs are blacker than the other 2 groups. So that blacker appearance suggests that there's more air in the lungs. And that's one of the tell signs of a COPD, is that air is trapped in the lungs. So we would expect to have a blacker lung, we would expect to have a larger volume. So we did the same thing. We did image-based measurements. So we measured airway diameters, the lung lobe length. We segmented the lung and major airways using a threshold-based algorithm. We can measure the mean volume, the mean CT number, so that gives us an idea of the composition in the lung. So all of our scans are scaled into CT numbers, which are relative to water or tissue. So we can, using the values that we measure, the grayscale values, we can determine what tissue type is present. We measured the low attenuation area, LAA. So that is a metric that's used clinically as a means of quantifying kind of the air trapping, the degree of air trapping in a patient, and calculated functional metrics similar to what I described earlier, the tidal volume and functional residual capacity. So this is an example of a segmentation. So we can segment out the entire lung. So that's kind of the lighter color shows the entire lung, and then the orange color is showing the airways, the major airways. And then you can see some regions that are not in an airway that also light up. So this is a measure of the LAA, so the low attenuation areas. So in this slide, I'm showing the change in the low attenuation area between the baseline scan and the endpoint scan. So if there's no change, we would expect that they would be around 0. So we don't see any significant changes, but we do see that there is a fair amount of variability in our 6-month and 3-month smoking groups compared to the control groups. Those are fairly large error bars. So the low attenuation area is something that is used clinically. I think maybe it's not something that you would necessarily see in a stage 1 or a gold 1 or a gold 2. It might be a later stage. And unfortunately, it's difficult to get to a gold 3 or gold 4 level in rodents. So this is something that we didn't really see a lot of, but it could be more related to the stage that we're at. We did see a difference in the functional residual capacity. So again, these are differences. So the 6-month smoke exposed group had a higher functional residual capacity than our air exposed group at the same age. Both of them did increase in the functional residual capacity from their baseline, because over 6 months they did gain a fair bit of weight, and so they were bigger. So this is also an indicator of air trapping in the lungs. And in the tidal volume, we see a lot of variability in the smoke-exposed mice at 6 months, 3 months, even 1 month. Not a lot of statistical differences. We did see a small statistical difference at 3 months. So this is a measure of how much air is breathed in and breathed out on average. And in COPD, this isn't normally something that is a big symptom. It's more air trapping, and not as much, at the early stages at least, it's not as much about how much air they can get in and out. Their exchange is reasonable at the early stages. It's just the air trapping that becomes a problem. And then we also did the tidal volume to resting inspiratory volume. So this is similar to a metric that is used clinically. In this case, we have a reduction for our 6-month smoke-exposed group that is statistically different from the non-exposed group. So we did see a few metrics that showed statistically significant differences. We also did histology in these animals. So in the histology, we have the top row is our 1 month, the middle row is the 3 month, and the bottom row is our 6 month exposure groups. And then we have the air exposed on one side and the smoke exposed on the other. So the first set of panels that are fairly pink, these are H&E stained. So all the connective tissue is pink, and so you can see really well all of the alveolar spaces with a nice tissue all the way around for air exchange. And so in the 1 month group, we don't see a lot of differences. 3 month, we don't see a lot of differences. But in 6 month, you can see that some of these septa have now degraded. And so that's where the air trapping comes in. So there's big pockets of air in the lung that doesn't have a place to exchange. On the far side, we have our trichrome stain. So in our trichrome stain, we have brown color is the nucleus of the cell, the reddish color is the muscle, and the bluey green color is collagen or fibrotic tissue. So you can see that there are a few differences as we go down from 1 to 3 to 6, not a huge amount of change. So the quantitative measures that we made on our H&E stains, we measured the average length across the different alveoli. So we just picked a whole bunch of places, we put a line down and measured the length of the line that would fit inside the alveolar spaces. And we saw the 6 month group did show some differences from the smoke exposed, between the smoke exposed and the air exposed group, and the other two groups had no difference. And for the trichrome, we calculated the total amount of that image that was colored in that bluish color. And so we didn't see a statistically significant change, but you can see a little bit of an upward trend. So there might be a little bit more collagen, but it doesn't seem to be significant at this stage. Again, our mice are probably a stage 1 or stage 2. So this is something that would probably continue to build over time and would be much more significant for a more severe COPD model. So the conclusions for this study is that we were able to use in vivo respiratory gated micro-CT to measure changes in lung function between smoke exposed and air exposed mice. And we did find at 6 months, there were significant differences in functional residual capacity, indicating a increase in air trapping and the tidal volume to resting inspiratory volume. All of our results were consistent with what was in the literature, but all of the literature results were kind of post-mortem markers. So we might be able to see some of the things that you would expect to see in patients, but a lot of the more severe characteristics might not be achievable in a mouse model. So it's kind of understood that we might be able to get a gold 2, but we might not be able to get all the way to a gold 4 in this type of a model. So I'm just going to go to the last couple of slides to give you an idea of what's next. So we know that smoking is declining, but e-cigarettes are rising in popularity. And so we're interested in looking at e-cigarettes and vaping. The Canadian Tobacco and Nicotine Survey in 2022 found that about 30% of adolescents and 48% of young adults in Canada reported having tried vaping at some point. And this is an increase from 2019. where both groups were at 20%. So it seems to be increasing very quickly in popularity because it's considered to be safer than tobacco. It's marketed as being safe. Unfortunately, there are a number of known carcinogens that are present in vaping. And there's also the possibility of heavy metals, arsenic, chromium, all those sorts of things. So we wanted to know, do e-cigarettes have a negative impact on respiratory and or oral health? Because we know tobacco cigarettes have an impact on both. It's implicated in chronic obstructive pulmonary disease and emphysema. It also is a cause of lung cancer. It's a cause of oral cancer. So are any of these things going to happen in vaping? So in 2026, we are ramping up to start a study. We will be vaping mice. So some of the mice will get a nicotine product, some of them will get nicotine-free product, some of them will get a THC, and some of them will get THC with vitamin E acetate. So THC is the active ingredient in cannabis, and the vitamin E acetate is supposed to make it more palatable if it's mixed together. But all of these ingredients, nicotine, THC, and vitamin E acetate, have been implicated in something known as EVALI, which is a e-cigarette and vaping related lung injury. And there was a whole bunch of them that hit the news in probably 2019 across the US and Canada. And then it kind of disappeared from public view. So I guess the news found more interesting things to report. But I don't think it was ever resolved. Are these things hazardous or not? And why did all these people get this lung injury? So we're going to do a fairly comprehensive study. So we're going to look at the fluid. We're going to look at the vapors and aerosols it produces. We're going to look at excised tissue from the mouse, looking at lung, tongue, and palate, because those are the sites where you would get lung cancer or oral cancer. We're going to look at micro-CT. So we're going to take micro-CT images of the lung before, during, and after vaping for 6 months. We're going to look at changes in the bone, in the nasal cavity, in the oral cavity, because these things can be affected by nicotine in cigarettes. So maybe nicotine in vaping would also affect it. And we're going to look at microscopy to look for changes in the tissue, in the lung, the oral cavity, and see what we can find. I don't know what's going to come out of it, but we're excited to try and see, and use all the different techniques that I've talked about today. So that's brings me to the end of my presentation. So hopefully you kind of see how I use imaging as a way of studying tissue and lung function, and in live breathing happy little mice.